We are going to talk about acute renal failure. The new terminology is acute kidney injury. 60% of the ICU patients experience an acute deteriorations in renal function. It has multitude of etiologies. 15% of the patients require renal replacement therapy. We did a seminar on renal replacement therapy 2 weeks ago. As many as 60% of the patients will not survive in spite of our best attempts. So identifying acute kidney injury and avoiding it has most beneficial effect. The term acute renal failure was introduced in 1951, almost 70 years ago. The term acute kidney injury was introduced 2002. 10 years later, in 2012, the defining criteria for acute kidney injury were adapted and published as the Kidney Disease Improving Global Outcomes Guidelines. So what are the diagnostic criteria for acute kidney injury? It should fulfill one of the following conditions: an increase in serum creatinine of more than 0.3 milligram per deciliter, or if you use micromoles, more than 26.5 micromoles per liter within 48 hours. An increase in serum creatinine to more than 1.5 times from the baseline within the previous 7 days. Or urine volume less than 0.5 ml per kg per hour to the ideal body weight for 6 hours. So one of these criteria fulfill the diagnosis of acute kidney injury. There are some limitations. The presence of oliguria, which is defined as urine output less than 0.5 ml per kg per hour, can be an appropriate renal adjustment to decreasing in renal function rather than a sign of kidney injury. And also, there is a lack of agreement about the minimum increase in serum creatinine required for the diagnosis of acute kidney injury. The baseline serum creatinine may not be known. The serum creatinine can be misleading as a marker of glomerular filtration rate, as described in the next slides. The serum creatinine is the traditional marker of glomerular filtration rate, or otherwise called GFR. However, the serum creatinine level has the following limitations as a marker of the GFR. The creatinine in blood is derived from creatinine produced in muscle. Thus, is influenced by muscle mass and the rate of creatine production in muscle. So in patients with myopathy and muscular dystrophy, you will have a distorted information on the GFR. The serum creatinine concentration is influenced by changes in plasma volume. So creatinine is not only filtered at the glomerulus, but also secreted by the renal tubules. So these are all certain limitations of using serum creatinine as a marker for glomerular filtration rate. So what is the alternative? Cystatin C. Cystatin C is a protein produced by most cells in the body that is not completely cleared by the GFR. Serum levels of cystatin C are not influenced by muscle mass, which gives cystatin a potential advantage over creatinine. Estimates of GFR based on the serum cystatin C levels are more accurate than creatinine-based estimates, but they often underestimate the true GFR in critically ill patients. So the combining cystatin-based and creatinine-based estimates of GFR increases the accuracy further. So no one is perfect, but combining both cystatin C and creatinine will give accurate GFR. But unfortunately, cystatin C-based GFR is not available everywhere. So what are the common causes of acute kidney injury? So there are 3 mechanisms that can cause acute kidney injury. Those are all inflammation, hemodynamic compromise, and nephrotoxic. By inflammation, major surgery, multi-system trauma, and sepsis can cause acute kidney injury. In cardiac arrest, heart failure, hemorrhage, increased abdominal pressure, and liver failure can cause acute kidney injury via hemodynamic compromise. There are lots of nephrotoxic agents can cause acute kidney injury as well, like radiocontrast dye, rhabdomyolysis, and nephrotoxic drugs and toxins. So this is the simplistic diagram of how the filtration occurs at the glomerulus. It depends on the three pressures. One is arterial pressure, second venous pressure, and third the proximal tubular pressure. These three pressures determine the glomerular filtration rate. In other words, glomerular filtration rate is equal to the difference between arterial and venous pressure and also the tubular pressure. So flow through the glomerulus is determined by the difference between arterial pressure and the renal venous pressure. This is called glomerular filtration pressure. The net filtration pressure across the glomerulus, that is called filtration gradient, is a difference between glomerular filtration pressure and the pressure in the proximal tubules. So the filtration gradient is PA minus PV minus PPT. So GFR will decrease when there is low arterial pressure, easily understandable. Second, increase venous pressure, the renal venous pressure or central venous pressure. When it is high, again, it affects the glomerular filtration. So she's going to see in patients with heart failure. Third, increase in pressure in the proximal tubules itself, like what you see in acute renal injury caused by nephrotoxic environment. Sepsis is the most leading cause of acute kidney injury, and is responsible for about half of the case of acute kidney injury in ICU population. The principal mechanism by which sepsis causes injury is the inflammatory injury involving both capillary endothelium in the glomerulus and the epithelial lining of the renal tubules that causes acute tubular necrosis. The acute tubular necrosis resulting in sloughing of damaged vessels and results in luminal obstruction. It increases pressure in the proximal tubules and thus decreases glomerular filtration rate. This is called tubuloglomerular feedback. The causes of the incidence of acute kidney injury varies in different circumstances. For example, in patients with the liver transplantation, the incidence of acute kidney injury is 50%. In cardiac surgery, the incidence is 18%. Abdominal surgery, 13%. The multi-system trauma, 30%. And rhabdomyolysis, 1/3 of the patients will have acute kidney injury. It's very important in these circumstances, avoid the causes of acute kidney injury and also do the prophylactic measures so that you don't end up in acute kidney injury. The most important when we discuss about acute kidney injury is cardiorenal syndrome. Heart failure and renal functions or renal dysfunction are common companions. Renal dysfunction was present in 63% of the patients. Association between heart failure and renal impairment is known as cardiorenal syndrome. So when you have renal impairment with heart failure, the chances of going down the hill is much higher. So avoid renal dysfunctions in patients with heart failure. The renal impairment associated with the heart failure has traditionally been attributed to a decreased renal perfusion pressure. But the increase in central venous pressure in heart failure also plays a role in reducing GFR. The decrease in renal perfusion pressure plays a major role in renal dysfunction associated with heart failure. So not having effective stroke volume definitely plays a role, and also increase in central venous pressure. Being ineffective or venous stasis also plays a significant role. That's what it means. That means any disorder that results in Pulmonary hypertension or heart failure can cause acute kidney injury. So you need to address the right heart failure and the left heart failure in order to prevent acute kidney injury or acute renal failure. The second major group is abdominal compartment syndrome or ACS. It is an increase in intra-abdominal pressure that is great enough to cause dysfunction in one or more vital organs. Organ dysfunction usually involves bowel, kidneys, and or cardiovascular system. ACS is more common than suspected in critically ill patients and often overlooked as a cause of acute kidney injury in ICU patients. I do not want to understate this statement. It is the most underdiagnosed and under treated. But if you follow the bladder pressure, you can easily identify abdominal compartment syndrome and you can act upon it. Most of the time, you need to open up the belly or remove the fluid or both. So what are the relevant pressures in abdominal compartment syndrome? Intra-abdominal pressure is normally 5 to 7 millimeter mercury in the supine position. Intra-abdominal hypertension is defined as supine intra-abdominal pressure more than 12 millimeter of mercury. Abdominal compartment syndrome is defined as supine IAP, which is intra-abdominal pressure more than 20 millimeter of mercury that is associated with acute kidney injury or acute dysfunction in another organ systems. So keeping IAP below 12 is optimal, definitely below 20. When IAP exceeds renal venous pressure, the driving pressure for glomerular flow is the difference between mean arterial pressure and the IAP. So driving pressure usually arterial pressure minus venous pressure. Here, the intra-abdominal pressure is so high, the driving pressure becomes arterial pressure minus intra-abdominal pressure. That is called abdominal perfusion pressure. The APP needed to preserve renal blood flow is not well defined, but studies of patients with IAH, intra-abdominal hypertension, and acute abdominal compartment syndrome have shown that APP, abdominal perfusion pressure, more than 60 is associated with improved outcomes. So reducing intra-abdominal pressure is critical component of improving or avoiding acute kidney injury and also other organ injury in patients with abdominal compartment syndrome or intra-abdominal hypertension. When the IAP is increased, the pressure in the proximal tubules is considered equivalent to IAP. So the filtration gradient is determined as the arterial pressure minus intra-abdominal pressure of 2 times. So intra-abdominal pressure plays a significant role in causation of acute kidney injury. Is very important. As I said, it is often underdiagnosed and undertreated even in United States. This relationship predicts that increase in IAP will have a greater impact on the GFR than equivalent decrease in arterial pressure. This might explain why oliguria is one of the first signs of abdominal compartment syndrome. When there is a low urine output, in case if you are not monitoring, that should raise the suspicion or abdominal compartment syndrome, you should remedy it most of the time by surgical means. Abdominal compartment is traditionally associated with abdominal trauma or surgery, gastric distension, bowel obstruction, ileus, ascites, bowel wall edema, hepatomegaly, positive pressure breathing, upright body position, and obesity. Several of these factors can coexist in critically ill patients, like obese patients with sepsis, which explains why IAH is discovered in as many as 60% of patients in medical and surgical ICUs. Crystalloid resuscitation can rise the IAP by promoting edema in abdominal organs, especially in the bowel, which is a normal process in any kind of resuscitation. If the positive fluid balance is more than 5 liters over 24 hours, IAH was present in 85% of the patients. It is major number. And the ACS was diagnosed in 1/4 of the patient, which is 25% of the patient. This observation adds to the growing consensus that avoiding positive fluid balance will reduce the morbidity mortality during the ICU stay. That is the reason the recent guidelines, 2021 SCCM guidelines in sepsis resuscitation, they have come down to 30 ml per kilo of fluid bolus rather than 60 ml per kilo of fluid bolus. So how to measure intra-abdominal pressure? The following conditions are required for measurement. The patient must be in the supine position with the pressure transducer zeroed in the mid-axillary line. Small volume of isotonic saline is injected into the bladder 30 to 60 seconds prior to each measurement. IAP is measured only at the end of expiration and only when there is no evidence of abdominal muscle contractions. IAP measured in millimeter of mercury, not in water pressure. 1 millimeter of mercury is equal to 1.3 centimeter of water. But in reality, most of these patients have compromised respiratory function because of the abdominal distension. So these patients often are well sedated, intubated, and on hyperosmotics. So these patients will have bladder catheter with the pressure monitor transducer. It automatically reads what is the pressure is. The important thing is act upon it when the pressure exceeds more than 12, definitely when it exceeds more than 20. Don't wait for oliguria to appear. The second group is called hepatorenal syndrome. Acute kidney injury has been reported in 50% of patients with end-stage liver disease. Hepatorenal syndrome is a serious condition caused by the diversion of blood flow away from the kidneys due to the combination of renal vasoconstriction and splanchnic vasodilation. CHRS typically carries a very poor prognosis, with the liver transplantation being the definite treatment. So what are the nephrotoxins? Again, we have grouped into 4 different categories based on the mechanism: altered hemodynamics, osmotic nephropathy, renal tubular injury, and interstitial nephritis. Among the altered renal hemodynamics, the most common we come across exposure to non-steroidal anti-inflammatory agents, very commonly prescribed, especially when you combined non-steroidal anti-inflammatory agents with other nephrotoxic agents like vancomycin, or when you use during hypoperfusion states like hypotension, then the chances of developing acute kidney injury is much higher. And the other drugs are AC inhibitors, angiotensin receptor blockers, cyclosporin, and tacrolimus. Hydroxyethyl starches can cause osmotic nephropathy. Mannitol in intravenous immunoglobulins also can cause osmotic nephropathy. Aminoglycosides known to cause renal tubular injury, so you have to measure and monitor the levels whenever you prescribe or give aminoglycosides. Other notorious agents are amphotericin B, antiretrovirals, and cisplatin. Most of these patients will get fluid boluses and monitoring urine outputs whenever you use amphotericin B and cisplatin. And there are commonly used medication can cause interstitial nephritis. The most cited are penicillins, cephalosporins, sulfonamides, vancomycin, and macrolides. Anticonvulsants such as phenytoin, valproic acid, H2 blockers, non-steroidal anti-inflammatory drugs, and proton pump inhibitors can cause interstitial nephritis. The other most commonly thought and anticipated is whenever you use radio contrast dye. Radio contrast dye injections do not increase the incidence of acute kidney injury in critically ill patients as such. And also, they do not worsen renal function in patients with pre-existing acute kidney injury. However, iodinated contrast dye is still considered risky in patients with chronic kidney disease when the GFR is less than 30 ml per minute per 1.73 square meter body surface. So it is not as feared as it was, but still you need to be careful when the GFR is low to start with. The prophylactic saline infusions are recommended for radiocontrast dye injections in patients with acute kidney injury or with an estimated GFR less than 30 ml per minute. This recommendation does not necessarily apply to patients with heart failure. Don't do this fluid bolus when the patient is already have a heart failure. The infusion should begin 1 hour prior to the study and should continue for 3 to 12 hours after the study. There is no firm recommendation regarding the volume infused. Typically, we use 20 ml per kilo. Next one is rhabdomyolysis. Acute kidney injury is the most serious complication of diffuse muscle injury, otherwise called rhabdomyolysis. The culprit is myoglobin, released from injured muscles and is capable of damaging renal tubular epithelial cells. The source of this injury may be the iron moiety in heme, which is capable of oxidative cell injury via the production of hydroxyl radicals. So, how to diagnose acute kidney injury because of myoglobin? Number one, you check the elevated creatine kinase. The CK level usually in multiple thousands. The second is identifying myoglobinuria. This is very critical component of diagnosing acute kidney injury. When there is very high level of CK level, and that time we usually take a prophylactic measures to prevent acute kidney injury. So urine myoglobin level more than 20 microgram per liter is the evidence of significant myoglobinuria. At that point, you will see the urine discoloration to brown. Myoglobin can also be detected in urine with orthotoluidine dipstick reaction hemostates. The way we do, especially even in here, resource limited areas, check for hemoglobinuria using dipsticks and check microscopic red blood cells in the urine. So if your hemoglobin is positive in dipsticks, but there is no erythrocytes seen under microscopy, it's most likely it's myoglobinuria. You can send the myoglobin, but most of the time the turnaround time is longer because we need the diagnosis faster. So how to manage? Aggressive volume resuscitation to promote renal tubular flow. It is the most effective measure of preventing or limiting myoglobin nephrotoxicity. Isotonic saline can be given 10 to 20 ml per kilo initially, then infused to maintain urine output of 1 ml per kg per hour. However, if oliguria persists after a few hours, it is important to abandon this strategy to prevent fluid overload. So identifying early is very important so that you can attempt to promote renal tubular flow. The second things we do in myoglobinuric patient is alkalinize the urine to keep the pH more than 6.5 with bicarbonate infusions. What does it do? It prevents the gas formation in the renal tubules. But one should be aware infusing alkalinization of urine has side effects. The most common side effect being hypocalcemia. Third is diuresis with mannitol or furosemide, again to promote renal tubular flow. But diuresis is risky because it's counterproductive to the planned volume resuscitation. That means when there is hypovolemia, giving diuresis. So you have to see what is volume status and aggressive volume resuscitation. Typically, what we do is we give a volume resuscitation along with furosemide and make sure the urine output is high and alkalinize the urine along with it. So it's a multi-pronged approach to prevent acute kidney injury in myoglobin equations. So diagnostic considerations in patients with acute kidney injury. Number one, get ultrasound. If the ultrasound shows small kidneys, that indicates chronic kidney disease. Sometimes they can say it's medical or surgical. And hydronephrosis will be evident by the big kidneys. So what are the urinary indices you follow in patients with acute kidney injury? One is to spot urine sodium. In patients with renal hyperperfusion or pre-renal, the urine sodium will be less than 20. When there is renal tubular injury, urine sodium would be more than 40. The fractional excretion of sodium would be less than 1%. Renal tubular injury, more than 2%. Fractional excretion of urea, less than 35%. In tubular injury, it will be more than 50%. Osmolality, more than 500 in renal hyperperfusion, because it is very concentrated. In tubular injury, 300 to 400. Urine over plasma osmolality will be more than 1.5. Renal tubular injury, 1 to 1.3. But there are, again, exceptions. When you are giving diuretics, that all will change, because diuresis, not only it causes diuresis, alcohol causes sodium loss. The urinary sodium would be high. That will affect fractional excretion as well as urinary sodium. And also chronic renal disease, because it causes obligatory sodium loss in the urine. So it may not be appropriate tool to use. So, but even then, we use fractional excretion of sodium more often than we see. Almost all the patients we do. So how do you measure it? Urine over plasma sodium divided by urine over plasma creatinine. In euvolemia, fractional excretion of sodium is 1%. In patients with hypoperfusion, high fractional excretion of sodium is less than 1%. Patient with renal tubular injury, fractional excretion of sodium is typically more than 2%. Again, you have to keep in mind the patient is not in diuretic therapy, or if that is patient is in diuretic therapy, you cannot go by these percentages, and also chronic renal insufficiency. But also the FeNA may be less than 1% in patient with acute tubular injury from sepsis or myoglobinuria. So keep that in mind when you're interpreting FeNA. What is fractional excretion of urea? The fractional excretion of urea is similar to FeNA. Instead of sodium, we use urea over creatinine. In this one, the fractional excretion of urea is low in hypoperfusion states, less than 35%. Renal tubular injury, more than 50%. One good thing about fractional excretion of urea is it is not influenced by diuretics. So that is one caveat. What we have found with FeNA is not there with fractional excretion of urea. But most of the time we do FeNA than fractional excretion of urea. So how to manage? Number one, fluid bolus, because most of the time acute kidney injury is caused by hypoperfusion state. It infused over 10 to 15 minutes. It's a very important thing. The rate of infusion is more important than the volume. So don't ask them to infuse 15 ml over, 20 ml per kilo over an hour or two. That may not work. Typically, what I do is ask them to get me a fluid, I infuse or bolus it and see that improves. Most of the time it works. It gives lots of feeling. Number one, it improves the tubular blood flow. And also you can see as you push the fluid, the heart rate comes down, the blood pressure goes up. So when that happens, you know for sure the tank is empty. So you can give more fluids. When there is no change, then you can stop. Or if you suspect cardiac dysfunction, of course, you go gingerly. So all these points you can do when you do and watch the parameters. But if you have stroke volume index, you can also check right away whether that improves with your fluid bolus or not. Change in stroke volume can be used to determine fluid responsiveness. Fluid challenges should be stopped if there is no response, the stroke volume or urine output. The next one is trial of diuretics. Trial of IV furosemide is a reasonable attempt to mitigate fluid accumulation in acute kidney injury, especially when the blood pressure and the heart rate is reasonable. Diuretic should never be given to increase urine output if renal hypoperfusion is a contributing factor. When there is a low blood pressure and high heart rate, don't try that one. Just give fluid. That's what the patient needs. IV furosemide does not improve the renal function. You should remember that one. It is used to convert oliguric renal failure into non-oliguric renal failure. It is easier to manage non-oliguric renal failure than oliguric renal failure. Second group is called low-dose dopamine. Dopamine at low dose range, especially 2 mics per kg per minute, can promote renal vasodilation, which led to popularity of low-dose dopamine as a treatment for acute kidney injury. We used this one for many years. This practice did not improve the renal function and had undesirable effects, such as decreased splanchnic blood flow. So the use of low-dose dopamine in acute kidney injury is considered as a bad medicine. We do not use, no longer this low-dose dopamine is used to improve the kidney function. Finally, renal replacement therapy. We have done a seminar on renal replacement therapy 2 weeks ago. It's uploaded in our YouTube channel. 10 to 15% of the ICU patients receive renal replacement therapy. The indications are symptomatic uremia or encephalopathy, volume overload. Most of the time we use for volume overload, or life-threatening refractory hyperkalemia, and of course, removal of toxins, especially TCS, tricyclic antidepressants, very important. Hemodialysis. HT is an intermittent form of renal replacement therapy that removes solutes by diffusion, which is driven by the concentration gradient of the solutes across the semi-permeable membrane. To maintain this concentration gradient, a technique called counter-current exchange is used. What does that mean? The blood is flow in the one direction and dialysis fluid driven in the opposite direction. Blood pump is used to move the blood in one direction at the rate of 200 to 300 ml per minute, while the dialysis fluid on the other side of the membrane moves at a higher rate, 500 to 800 ml per minute. It's simple logic. That's what we do. So as you can see here, this blood flow goes through that one, and the dialysis goes in the opposite direction in much higher rate. As a result, the solute clearance is happening based on the concentration gradients, because bad things are more here, less, so it moves out. Hemofiltration is driven by hydrostatic pressure in the blood. Then because of the high hydrostatic pressure, it filters out. It's called ultrafiltration. Each hemodialysis session lasts about 4 hours, and no more than 2 to 3 liters of fluids can be removed per session. Even though it's a small amount, still it changes a whole lot, especially in patients with critical illness. But most of the time, in patients with critical illness, their hemodynamics may not support hemodialysis. So we do CVBH. That is gentler way of removing the solutes and removing the fluid. The advantages of hemodialysis is a rapid clearance of small solutes. It is the best way to do it as of now. Only a few hours of HD is needed to clear life-threatening accumulation of potassium or to remove days' worth of accumulated nitrogenous waste. So it's very effective. The disadvantage is slow removal of small fluid, which is not well suited for clearing nitrogenous. For me, its disadvantages. Only thing is it causes hemodynamic perturbations. So as a result, we routinely do CVVH rather than HD in patients with critical illness. Another mode is called CVVHD. So filtration and dialysis together. It benefits of dialysis, that is rapid clearance of small solids, and hemofiltration, removal of fluids and toxins, can be delivered as a continuous. So it's a gentler form of removing, which it goes on 24 hours for a couple of days. This is the most favored method of renal replacement therapy in the ICU. It works beautifully well. It doesn't affect the hemodynamic. Well, it doesn't affect that much like hemodialysis, and it's very gentler form of removing the solids and removing the fluid. This concludes the seminar on acute renal failure.